The ARMA trial in 2000 determined the role of lower tidal volumes in acute lung injury and acute respiratory distress syndrome. This continues to lay the foundation for lung protective mechanical ventilations, which are used today in the medical ICU. The ARDS network, composed of multiple clinical centers, aims to provide guidelines for the lung protective mechanical ventilation based on this ARMA trial. Specifically, the site provides FiO2 to PEEP tables that allow for step-up or step-down ventilator changes, including both lower PEEP, higher FiO2, and higher PEEP, lower FiO2 options. This study evaluates FiO2 and PEEP values entered into patient ventilators compared to ideal values as described by the ARDS-NET. This study aims to determine the percentage of adults receiving mechanical ventilation in the medical ICU who have lung protective FiO2 and PEEP values entered into their respective ventilators within the first 12 hours of ICU admission. The study further aims to determine if the addition of an official ARDS-NET FiO2 PEEP table to each respiratory therapist computer workstation increased compliance with lung protective ventilation. A single-center retrospective observational review was conducted following IRB approval to assess compliance with lung protective FiO2 to PEEP strategies and mechanically ventilation. This study included patients admitted to the medical ICU between July 1st, 2023 and February 2025. An intervention was implemented on July 1st, 2024, consisted of adding FiO2 PEEP tables to respiratory therapist computer workstations. Inclusion criteria included patients greater than 18 with acute lung injury or ARDS requiring mechanical ventilation. Pregnant patients and those extubated within 12 hours of ICU admission were excluded. Due to limited prior research, a formal power calculation was not performed. Of 187 reviewed patients, 87 were excluded for not meeting primary lung disorder criteria, leaving 100 patients, 48 pre-intervention and 52 post-intervention for analysis. Results showed 51% of patients were compliant with lung protective FiO2 PEEP values within 12 hours. Compliance was 50% before and 52% after table implementation. The difference was not statistically significant, with X squared of 0.0369 and a p-value of 0.8476. Lung protective ventilation, as established by the ARMA trial, has been shown to reduce both morbidity and mortality. Despite this, adherence to recommended strategies remains suboptimal, with prior studies reporting compliance rates under 50% within 48 hours of ICU admission. This study found a similar 51% compliance rate within the first 12 hours, emphasizing the need for targeted interventions. Previous quality improvement studies have explored various facility-level strategies to improve compliance, including bedside whiteboards, QR codes, documentation of ventilation targets, and regular auditing. Successful interventions often involved interdisciplinary collaboration and education. In contrast, our study used a single modality approach by adding FiO2 to PEEP tables to a respiratory therapist workstation without concurrent education or communication initiatives. This may explain our lack of significant improvement. Although the intervention alone did not significantly improve compliance, it remains a practical and low-cost strategy. When combined with interdisciplinary education and structured protocols, it could enhance adherence to lung protective mechanical practices. This finding also aligns with prior literature suggesting potential generalizability to other institutions. This study, however, lacked randomization and a power analysis, limiting its ability to detect small but meaningful effects. As a retrospective review, it was subject to potential confounding variables between pre- and post-intervention groups. Additionally, the absence of educational reinforcement may have diminished the impact of the intervention.